no one can fully prepare for. Should the unexpected These are something that no one can fully prepare for. Should the unexpected happen, we at Solomon Sticks Morewa are prepared to do anything imaginable to speed up your rehabilitation. We do this by maximizing our patients' level of independence and functioning abilities, as well as by educating and training patients and families to support the recovery. We provide high-quality, cost-effective therapy in a serene setting with a focus on achieving concrete, quantifiable results that are ideal for both adult and pediatric physical rehabilitation. Our facilities are revolutionizing patient outcomes through personalized physical therapy programs and maximizing patient progress through our hydrotherapy pool. Our professional team consists of physiotherapist, occupation therapist, and highly competent nursing team with an aim for the best physical rehabilitation results. We are open 7 days a week and ready to welcome you.
Good evening, colleagues. I hope you can hear me. And that was a very short video clip. I wanted us to play longer. I say that we're playing very short. My name is Raymond Bila, Group Medical Officer for Tenix Health Group. And we just want to welcome you once more to our weekly webinars here at Clinics, as we host these webinars every Thursday evening between 6 and 7 p.m. And we trust that this evening also we'll have a wonderful time with us as we continue to share the insights on continuing medical education. And it's no exception even this evening with the team that we have that will be presenting this evening. So as it happens every week, these webinars are CPD accredited. I know in the last few days, it looks like the HPCS has been quite hectic, issuing certificates or notices and sending messages to colleagues that they are non-compliant and that they have not reached the maximum CPD points required. If you do have problems with knowing whether you've submitted your CPD points or not, please do not hesitate to get in touch with us. But we've done our best to make sure that anybody who has registered for these meetings, we've submitted their points and their attendance register so that the HPCSA can acknowledge them and allocate the necessary CPD points for them. But in case you're one of those 1 or 2 people who are affected, please do not hesitate. As mentioned, these webinars are also streamed live on YouTube, so you are able to access the presentations after we've done the weekly presentations on YouTube. At any time, you can go and view them. But make sure that when you register, you submit, you give us your full details, name, surname, registration number, whether you're the HPCSA, the Nursing Council, or the Allied Health Professions Council, whichever is relevant, so that we can upload your information and send it to the HPCSA. And this evening, we're quite excited that we are showcasing one of our facilities, Solomon Sticks Morewa Memorial Hospital, that we have some of the colleagues who will be presenting, about 3 of them or so, but they'll be led by Dr. Megan Knox, who is a physiotherapist by profession. And Dr. Knox is the clinical director for the Retahen and partners based at the Solomon Sticks Morewa Memorial Hospital rehab facility. She has a PhD in physiotherapy from the University of the Witwatersrand. She boasts a wealth of experience with over 30 years as a physiotherapist. Dr. Knox is a member of the South African Society of Physiotherapy, including Energy Specialist Interest Group. She was awarded the Best Oral Paper Presentation at the Stroke and Hypertension Conference in 2014. Retahen and Partners Incorporated is a group of therapy practice offering a multidisciplinary therapy practice including physical rehabilitation. The team is made up of occupational therapists, physiotherapists, and speech therapists. It is tailor-made, it tailor-makes intensive rehabilitation programs, giving each individual the opportunity to achieve maximum independence following a traumatic event in their lives. Added to the modern facilities, we now have the equipment that they're using at our own facility at Solomon Sticks Morewa, which is a clinic's health group facility. So this evening, Dr. Megan Knox will be talking to us about the from challenge to progress, the physical rehab journey. So we just want to welcome you, Dr. Megan Knox and team, to this webinar, and we're looking forward to be getting a lot of information about how to assist our patients who need to be admitted to a rehab center like the one we have at Solomon Sticks Morewa. Thank you and welcome.
Thank you, and thank you very much, Dr. Billa. I'm not sure if Mr. Bennett would like to start. I will share the show.
You start first. We'll handle that, yeah.
And let me just make sure I share. And when I get it shared, which I am doing, I just need to make sure my sound settings are correct, which is already done. So I'm good with that. And again, to give me another moment while I move this little bar.
She brings the slides up.
I am. I'm just having a challenge with the taskbar is suddenly in the way of the to start the slideshow. So I'll do it like that. I'll use a different way. Right. Good evening, everybody. Mr. Bennett, would you like to start with the first two slides?
Thank you very much. Good evening, colleagues, and thank you for the opportunity. Thank you for joining us. Thank you to Dr. Billa and team for creating this opportunity. Well, we represent clinics Solomon Morewa Memorial Hospital, an amazing team of passionate therapists and clinicians. And we have really made a few commitments. Commitment number one is that we are focused on functionality, improving the functionality of our patients, firstly to return back to home, but return back to work, and more importantly, to be economically viable. So the entire facility is a 750-bed facility, focusing on all areas of rehabilitation across mental health to physical rehabilitation. We have a 100-bed physical rehabilitation ward, of which 8 of those beds are pediatric beds. We are still awaiting licensing for ventilated beds, but that's in our plan. We make sure that we ensure the functioning abilities of patients are maximized through all the work we do here. And we have upgraded our facilities. We've upgraded our hydrotherapy pool. We have also added outpatient services because of the different needs in the community. But more importantly, like I said, we are committed to ensure that the patients, to the best of their capability, return to work, return to home and community, but more importantly, when they leave, that they are economically viable. So we have, in addition to our program, our therapy program, our clinical programs, we also have what we call a sustainable livelihood center, where we have partnered with various institutions like the Department of Agriculture, the Departments of Small Business. We teach them various skills. They all leave with computer skills. They leave with financial skills. They leave with entrepreneurial skills. We have a vegetable farm. We have a chicken farm on site. We have various skill centers like a fashion hub, a beauty hub, a audiovisual hub, and also in the arts area. So that's our facility. And let me hand back to the team who does amazing work. And we see lives changed. We see patients arriving in stretchers from the acute settings, but we see them really returning back. And more importantly is the joy that it gives the families to see the hope restored in their patient that they may have last seen in the ICU setting. So let me start by thanking the team and wishing them, just saying that well done to all the work they do and the lives they are changing. So back to you, ma'am. Thank you.
Thank you very much. And I think I must also just do an extended thank you and welcome to hopefully Monica Dube, who is part of Dube and Potas, who is hopefully with us. We'll be doing social work insights, as well as Dr. Mate, who our medical doctor shall be sharing some insights as well. But I'm going to be starting off giving you some insights into rehabilitation, which you might already have, but then also sharing a little bit of a case study presentation of one of our wonderful patients we've had at Sticks. And I must be honest, it's been the most rewarding, wonderful experience for Return and Partners to be involved at clinics. And of course, Solomon Sticks in particular has been a wonderful journey so far. So thank you.
Sorry, Dr.
Yes.
Knox. Come here. If you can maybe share your video, open your
I
video.
need permission.
Okay.
It's not allowing me to.
All right. Let me fix that now.
Okay. Do you think it's
Is
fixed?
it okay now? Yes.
Yes, it is. I
Thank
think
you.
it is.
Thank you.
Is that better? Cool. So that's good because I do speak with my hands and with a lot of facial expression. What are people's expectations of rehabilitation? And that's always where I start. And I think often what people are wanting is an engagement with themselves, with the patient, with the family, with their experiences. So often what's expected as service providers and as hospital service providers is a compassionate, ethical, patient-centered approach is what people really want. But they also want value. We all want everything at the lowest cost we can possibly get, which is really tricky because efficient use of resources has, I think we're quite aware, become more challenging in healthcare, especially with duplication of services, which becomes wasteful. But ultimately, what people also need and require is safe discharge. And this reality that I want to try also point out is that I think so often we forget that in the biomedical model, we're making patients and people better, but how do we help get them to cope in life and in society once they are discharged? So with all of this in mind, we have to do this with lowering costs of healthcare. And I think we're all experiencing the squeeze of funders and various areas. So we need to consider the fragmentation of services, which is becoming problematic, and duplication, which is adding to the cost and making it more complicated, but to try still ensure continuity in care. And so, of course, we are in an era of value-based purchasing in healthcare. So I always like to emphasize that our world is changing. It's changing actually extremely rapidly. And I am a very powerful advocate, strangely enough, and I don't know if I should say that here, of an NHI approach. We need something that is for all people and provides greater services to all. So what we somehow need to find is to be patient advocates, work for successful discharge. We all want optimal outcomes. Everybody wants that. But we also want no complications. But at the same time, we need to eliminate waste and be cautious of that and balance the scale with cost effectiveness and with efficient use of resources and services. So the question is in rehabilitation is, what does the evidence show? And sadly, not enough people are being referred to rehabilitation and are struggling at home. In fact, we just this last week had a patient admitted with a CVA who didn't realize that rehabilitation was an option and has been doing a lot himself, actually, amazingly, through YouTube. But there is so much potential. But the first 6 months is crucial. The most rapid recovery occurs in that period. It is thereafter that it starts to taper and slow down. And so referral is extremely important. The reason being is, I think you can almost see it in society, the difference between enriched, complex environments that provide sensory motor stimulation and functioning, which optimally, obviously, increases outcomes. The more someone hits a golf ball, the better you get at hitting a golf ball. So more intensive therapy increases plasticity in the brain, and that's exactly what's happening. And then, of course, these additional gains ultimately lead to the true crux of reality, which is social and reintegration into the community and good functioning, which is more important. I think our challenge is, and I always say it's the strangest thing, when people come to hospital, we put them in little beds and we have bedside tables, we put them in gowns, we bring food to them. We take everything away. And I know often they're unwell, but the problem is the environment is so often physically inappropriate. And because we're cutting costs, we're making things smaller. And we are very fearful. The culture of healthcare is often caring and risk avoidance. We're worried about falls. We're worried about what risk we might carry. And so the temptation becomes that we're starting to do too much for people and we're taking away their independence, which is adding to the problem because we know lack of mobility at movement is one of the best forms of medicine. So often services fail to set the appropriate goals and to get people mobilized and active. So one thing I'll just emphasize here is the importance of a coordinated rehabilitation team is that you cannot believe the amount of integration and multidisciplinary meeting discussion that goes on. And I often feel that that is what is more critical sometimes, that is really empowering the process in patients. So we use a thing called RPMs, Rehabilitation Program Managers, over and above case managers to facilitate the process. We also have regularly scheduled, in fact, weekly MDT meetings where every single patient is discussed with the entire team. Now, I know people have heard this all before, but it really is the most important part that makes the critical difference, to understand the person. We need and want to encourage routine involvement of carers, families. Get the families in. We can empower them, train them, educate them. They can actually so often become a mediator, a therapist at home. You also need specialized staff. I'm a great believer in the McDonald's concept, which if you're ever interested, we can have a presentation on that it's about efficiency, that if something is produced efficiently all the time, someone gets really specialized at it. And you know, without a doubt, what a McDonald's burger will look like. So it's well standardized. So standardization is essential, and early assessments to decide what does the person want, because the quickest way to get that outcome is to know what we want and what we need. So early mobilization out of bed, as obvious as it may seem, we're not doing enough of it, and really making it more real life. Get up, get dressed, get out of bed, walk to the dining room for your breakfast, etc. Go to the bathroom that's further away. These are the realities. And of course, we all want prevention of complications. So the best, I think one of the most important things that happens in an organized, coordinated multidisciplinary team is that we aim to stick to best evidence and practice all the time. So we do ground ourselves in terms of practice guidelines, and I talk about this myself often in terms of value-based rehab, because South Africa doesn't actually, we have a lot of paper documents, but we don't often stick to guidelines and really integrate them. So that is our focus at Solomon Sticks, to improve the quality of care. Not always the quantity, it's about effective quality. It's about the optimal timing. It's also about, I'll just introduce the concept of stratified care, because stratified care is also that concept of if there are similarities in subgroups that are grouped together in vicinity and proximity while working in a facility, you become really efficient and smooth in that area. And so it fast tracks patients to the appropriate treatments, and you've got less chance of things falling through the sieve or the net per se, that you get greater outcomes. So it aids clinical decision making and ultimately then leads to cost effectiveness. So the problem is many patients are having long-term residual disabilities, and not just, I think often people are thinking of big disabilities. The impact of simple illness, medically complex conditions, critical illness myopathies, neuropathies, long ICU stays, elderly people these days, unfortunately our population is aging with medically complex situations, maybe with a little bit of dementia, the effect of aging, who has a fall and fractures a hip but can't bounce back. This is what the critical issue is. So regardless of the nature of the underlying disease, the problem is we are so often getting people who can't cope and they need referral to rehabilitation, even if it's only for 5 days. But what I want to emphasize here is something that's written in red. Rehabilitation is not synonymous with physiotherapy or therapy. And I really need to emphasize that, because I think sometimes people think that is enough. It's not. It's the entire process and the team that's making it work. So the overwhelming dominance, and hopefully I don't offend anyone too much here, and some I often find oncological care understands this well, is that the biomedical model of illness naturally leads to part of this problem, because we diagnose and we treat and we cure the disease. But it fails to understand the impact of that on a person psychosocially. So just to show a few videos, and hopefully that'll play nicely for us, just some lovely patients and experiences we have had at Solomon Sticks. We have been working with RAF patients, WCA patients, and of course, aging populations, and getting great success. But I want to share something else. This lovely young lady was the standards manager of the Department of Education. I obviously changed her photos, but it is a true story. She was 58 years of age and was dizzy and walked into a wall, thankfully at work. So there were a lot of people around. She also experienced blurred vision. So of course, you know, with that, they sensibly took her to casualty. And of course, a lateral medullary infarct was picked up. The trick then is the biomedical model did a very good job. The MRI scan was done, it picked that up, they detected it. The hypertension for the first time was diagnosed and started to be managed. But unfortunately, she developed an aspiration pneumonia, which happened quite quickly. And I must emphasize, this is where often where you're dealing with patients in a certain area very quickly, you should know that a lateral medullary infarct is at high risk of cranial nerve involvement and what those consequences are. And of course, swallowing being affected. And so we see the poor lady where the risk factors were managed, the peg was inserted, appropriate management, and video fluoroscopy was obviously done before, etc. And so is the model. And the external treatments are what will cure the disease. And so now we need intensive therapy. And so the patient becomes this passive recipient now of some therapy being done. And so I say, we need to look at the person, not the disability. So I'm going to start again. Oh, and I forgot to fix this. I'm so sorry, but it doesn't matter. I'll explain it to you. I left my animations out. We need to throw the image that we see of the lady in the wheelchair out the window. And we need to look at this image of the lady at the end. She's only 58. She is married. She lives with her husband. She has a high level of education. She drives an automatic car. So as a therapist there, I'm quite excited because it's a little bit easier. She lives in a double-story house. So now I'm worried about the stairs. So you can see these pictures that were slightly overlapping. So it's a concern. It's something I need to think about. She likes to shower and she enjoys cooking. So to get her to be more active, I need to engage my therapy at a level of showering, not forcing her to bath. I need to get her into a kitchen. The sooner we get her into a kitchen, it's what has meaning and purpose to her. And that's what makes the difference. She loves reading African authors. So let's give her that material instead of other material. And she's involved in the church. That's wonderful. She has community involvement. So we want to engage and get her back set into that society and help them, if they are willing, because often church communities are, to be involved and engage with us. So we need a patient-centered approach that focuses on the personal context and the environmental context of the person. It takes a lot of work. I cannot emphasize it enough. And you made me sound very old earlier, Dr. Miller, saying 30 years of experience. But yes, it's a coordinated process. And I honestly can tell you it takes a lot of time and it takes a lot of coordination. But you have to persevere through that process with a lot of communication. Because personal context and environmental context are very different. And if you don't understand where someone is going, we easily end up doing the wrong things. I have seen patients being given bath chairs that when I've then seen the bath chair in their home, I noticed there was a rod in the way of the bath, so the bath seat couldn't actually be put in the bath, and it doesn't work. And it was an elderly person who prefers to shower. So let's rather put a plastic chair in the shower, but it does need context. It's not always a recipe. So I want to introduce you to Mrs. C. She is a wonderful lady that we had at Solomon Sticks. She was a 54-year-old lady, and she was employed as a vector controller in the environmental health department. She lived in Meadowlands, and in fact still does now, with her mother, brother, daughters, and her granddaughter. And she was quite involved in community activities. I must emphasize she had the most extremely supportive and amazing family. Her daughters were often around, and I never forget her one particular daughter, and I know her name and have her number, etc. And I was like, can we use her case study, etc. So we have a good context here, and it does differ in different environments. We know that, and that's part of the process. She was known to be hypertensive since 1998, and part of this problem, unfortunately, was she defaulted on her medication. So obviously, there's block number one. We really need to empower everyone and educate her about the consequences and what could happen, and how to monitor at home. She then developed a sudden onset of weakness, and obviously with the persistent headaches, and unfortunately suffered a hemorrhagic right basal ganglial stroke. And with some breakthrough into ipsilateral ventricle, but we were lucky enough that there was no midline shift. So she was actually managed conservatively and was a very nice referral that was from TTH. She was there on the 8th of June, March last year, 2023. And then obviously presented with quite a dense severe left hemiplegia, but was transferred to clinic. So thank you very much, TTH. And hopefully if any of you are online, you might recognize her at the end. For rehabilitation on the 27th of June. So hemorrhagic management, etc., came across. Quite quickly, we had concern about a query DVT. It was noted, and there was concern that her being hemorrhagic and managed conservatively, how to manage that. So she was referred back to TTH. But thankfully, I was worried at one point that she wasn't coming back, but she returned for rehabilitation on the 17th of the 7th. And now, if my dear friend Dr. Mate is there, he's going to share a little bit of their role. He wasn't involved in this case particularly, and I hope he can unmute and is there. We'll share what the medical management role is in rehabilitation. And he was not.
Hi, Megan.
Oh, thank you. Go ahead, friend.
Thank you. Thank you, everyone, and thanks for the invite. Mine is to have a small piece of this presentation, and I think correctly so, because, you know, the role of a doctor in a rehab team really is just to be the head and the overseer of the team. But most of the work done in rehab is actually done by the therapists and the nurses. In fact, a rehab team could probably run without a doctor, but ideally you should always have one. Now, my job as the doctor really is to look after the medical care of the patient. So control the hypertension, control the diabetes, manage the INR, you know, with the warfarin, etc. Also at times is to be the link between the team and the referring specialist. For example, a specialist may have done a ORIF on a patient and may want that patient should partially weight bear. Now it becomes my job as the doctor to liaise with the specialist to get the correct information to the team so that when we put together the rehab plan, it goes along with what the doctor has done. So really, my job is to keep the patient, quote unquote, healthy while the team does the actual rehabilitation. As much as I am the head of the team, I can safely say the doctor is not the most important person in the team. Everybody in the team is equally important. And I like what you said, Megan, and I need to emphasize this for other doctors. Rehab does not equal to physio. Even amongst physiotherapists specialize in different things. You get sports physios, you get rehab physio. So the physio you have in the hospital may be good at getting patients' knees straightened, but that doesn't mean to say that they are rehab physio. And rehab is about more than just doing physio. It's also about returning the patient to functionality. So the OT becomes important. So I would implore my colleagues really, as soon as you have a patient who you're diagnosed with a stroke, the rehab starts then. The speech therapist should be involved while the patient is in ICU, because we can start our assessment of swallowing and decide before they come through to rehab, should they have a PEG or do they not need one? So I really implore our colleagues to work with the rehab team so that we can achieve what all of us ultimately want, and that's the best quality outcome for our patients. With that, I hand back to you, Megan. Thank you.
Thank you very much. And you were very modest. I think this little lovely doctor could happily be a therapist, and he has a wide knowledge of the rehabilitation element. So thank you very much. So moving on, I'm not sure if you are aware, we do use very objective outcome measures, whether you want to look at the beta score, the FIM score. We use the FIM score. In rehabilitation, most facilities are almost required to, but it's extremely useful because it has a lot of interpretability. I'm not going to explain all of it now, but what I'd like to just emphasize is, so from the 17th when she was admitted, she had a total score of 33, which you can see on the far right. And by the time of discharge, which was only 4 weeks later, she had achieved 58. Her biggest improvements being in transfers. Transfers are a critical part, obviously, because transferring to a chair, a car, a shower elements are really challenging, as well as her social interaction, which was a huge part of who she was. So just to show that those scores had improved tremendously. I think my next trick is to hand over to the dietitian who's going to share some insights into rehabilitation, which is Dr. Sandra Kuhn. Bear with us if she is there. I did see her there earlier. Guys, you managing to find her, or should I move on and I can always come back?
She's still on the line. I'm not sure what's happening. Let me just.
Can she unmute?
Yes, she
She
can.
said she can't unmute. She's just sent me a message.
No, she can.
Try again.
Yes,
She's on
thank
mute.
you.
There you go.
It
Well done.
worked now.
Well done.
That's it. It worked now. Thank you, Megan, and thank you for inviting me to be a part of this. And for me, it's a privilege to be a part of the rehab team at Clinic Solomon Sticks. I love being a part of the team. I love engaging with the patients, and it's a privilege for me to present here tonight as well. So as a dietitian, I assess and treat patients with complex nutrition-related conditions, some of which directly will affect their physical function and then their journey in the rehab setting. So these would include conditions such as diabetes. Let me just start my video. Sorry. There we go. So these would include conditions such as diabetes, obesity, malnutrition, which we quite often see in the rehab setting, osteoporosis, anemia, patients with gastrostomy feeding tubes. And if a patient is not nutritionally stable, it may affect their potential it may affect or they may fail to reach their full therapeutic potential, which is a pity in the whole journey. A patient's non-compliant with diet, their lack of oral intake, altered nutrition-related labs, altered gastrointestinal function, decreased muscle mass, poor hydration, all of this may result in less than ideal therapy outcomes, which is what we want to prevent. The process of rehabilitation nutritional care has 5 steps, which is presented on the slide. So the first step would be is I do a complete rehabilitation nutritional assessment, and part of that is diagnostic reasoning. So I will do a diet history from a patient. So that would entail a medical diet history as well as a pre-morbid diet history. I do a clinical assessment looking at all relevant lab results. I do anthropometric measurements. I do observation. What can I see in the patient? And from there, I then formulate a rehabilitation nutrition diagnosis, which would then tell me what is this patient's nutritional status, if there's sarcopenia present, which tells me there's progressive and a generalized loss of skeletal muscle mass and strength. And this correlates very strongly with poor physical quality, disability, poor quality of life, and also it affects our therapy outcomes and goals, because what we ultimately want to do is we want to set our patient up for when they discharge from our facility and improved function and improved quality of life. So the next step would then be, after setting a diagnosis, I would then set my nutritional goals. What do I want to achieve while the patient is in rehab, as well as what is long-term goals? What do we want to achieve for this patient post-discharge? And then throughout this process, it's then the nutritional intervention, which is adjusted and adapted as we go along in the therapy journey, while monitoring this patient's nutritional status, and then also is working with the patient, working with the family, working with the caregivers to set this patient up for post-discharge, for function, for functionality, for quality of life, for maintenance, for maintaining a good nutritional status. And then it's a circular where there's a continuous assessment, and diagnosis and intervention and monitoring. So that's that's basically the dietitian's role in the rehab process. Thanks, Megan.
Thank you very much, Dr. Kuhn. So I'm going to bring you back to my lovely patients and try and show you a few videos, and you need to remember these for later. Just bear with me. Sometimes with therapeutic videos, it's a little bit slow, but you see she's falling over quite excessively. She took quite a while to learn how to get her balance. This pushy little therapist was trying to guide her and trying to get her to work on her balance and standing. And later it progresses to involvement with the family and trying to show them and train them. And this is quite a process, because I think sometimes as therapists, we make it look much easier than it really is. So it takes time to try get families to learn how to do the elements. And as I say, I really want you to try remember this when we look at some videos a little later. This is very early learning how to walk with the patient. And in fact, my next video, which was rather exciting, I don't know if a lot of you can appreciate that, is to start to get arm. It's really challenging to rehabilitate an arm. And it's quite exciting when patients start to discover that they do have some movement in the arm, and knowing how to really try and progress it and strengthen it, especially getting towards the shoulder and control of the hand, can be extremely challenging. In fact, for classic middle cerebral artery strokes, the arm is really a crazy challenge. But it's that opportunity that you can facilitate and try and help them to get some function out of that. But remember her, because in between, I'm going to quickly hand you over, if I'm correct, to the role of social workers, who guide us a lot of this reality of helping the family cope, to learn these skills and take them home. So I'm really hoping my very dear friend, Monica Dube, is online and is also available. You've got quite a challenge there getting everyone unmuted.
Good evening. Can you hear me?
It's perfect, Monica, thank you.
I would like to open up my video. It would not allow me. Unable to access camera, it says.
They'll get you going, and then just try again.
Hi, Ms. Dube, please try again.
It says okay, and it would not open. Okay. Start my video.
Yes.
Okay. No, it wouldn't. May I continue?
Go ahead.
Yes, I think, yeah. No, you may
seeing
continue.
my
I think it's a
face?
problem with the device.
Okay,
That's
thank
fine.
you. Thank you, and good evening, everyone. Thank you, Megan, for inviting us to speak on this platform. We're extremely grateful. And I would like to speak about the role of the social worker in rehab, especially physical rehab. Social workers form an integral part of the multidisciplinary team in rehabilitation. They are members of this team both in the inpatient arena and in the outpatient arena. They are the link between the team, the hospital, that is the facility, the family, the employer, the community. And usually they are the first contact that the family or the patient has in the hospital. Social workers help patients work through their feelings of uncertainty. Can you imagine being admitted into a hospital? You have a severe left stroke right hemi. You don't know whether you are coming or going. The amount of uncertainty would hamper your rehabilitation. So we help the patients to work through their feelings of uncertainty, their feelings of loss, their feelings of grieving over what they have lost. Megan showed us the lady from Zone 9. You just imagine what she has lost. So we help the patients to work through the feelings of grief and support them as they learn to maximize their independence and autonomy. How do we do it? The process. We first ensure that a comprehensive psychosocial assessment is done. And by comprehensive, I mean we ensure that we know this person as if we have lived with them. For instance, if Megan is my client, I need to know who she is, where does she come from, even where did she go to school. That says a lot about her. We need to know in which community does she come from. Communities are not the same. And because we are going to ensure that rehab will be client-centered. So this psychosocial assessment of ours is done to be a vehicle that can be used by the multidisciplinary team to meet the patient's needs and expectations. Our patients do have expectations. Even if they cannot talk, you speak to them, you ask, what would you like to do? Maybe the expectation is just to be able to take the spoon and feed themselves. Social workers also organize and chair a family meeting. I always say to the social workers, you cannot work with a patient or a family for 2 weeks without having made sure that the entire multidisciplinary team sits with that family. And the purpose of this is to share information with the patient and family. Note well, share, not to inform the family, not to inform the patient, but to share information. The multidisciplinary team will share information on what they have found in all their assessments. In this team, as Megan has said, we have an initial planning meeting where all the team members sit together and plan for this patient. How long will she be here? What goals would we like to have? So at this family meeting, we share information with the patient and the family. We also facilitate discharge planning, which is most importantly to assist with effective decision-making between the patient, family, and the treating team. Discharge planning is the most important part of rehab, because here we are going to look at reintegrating this person back into their community. A discharge plan cannot take place if you don't even know where the patient comes from. Therefore, a home visit is crucial. We heard Megan give us the scenario where a shower chair was put in the middle of an inaccessible bath. We have seen the steps in that lady's house. The home visit is most important, but mainly for me at the beginning of rehab. What we always say is that within 3 days, the psychosocial assessment needs to be completed. Within 7 days of admission, a family meeting has got to be done. And within 14 days of admission, a home visit needs to be done. The social worker takes the lead in this discharge plan. Sometimes our patient is in such a...
Monica, I think you might have bumped your mute button.
Let's see. Can
Yes.
you hear me now?
Yes,
Okay.
carry on. Well done.
Sometimes our patient is not in a position to be able to
It's happened again. There we go.
In our discharge plan, we many a times assist our family members to access the assistance of the Master of the High Court. That is part of our discharge plan. The social worker ensures that the aim is a smooth transition from the hospital to home, ensuring patients can safely function in their usual environment, thus reducing the number of readmissions. They ensure appropriate reintegration back into the community. Example, going to the facility or home with a carer, or ensuring return to work. Usually, we also would like the patient to go home for a home trial over the weekend with a trained carer. That will also enable a smooth reintegration into the community. Throughout the process, the social worker holds individual or group counseling with the patients or families. They liaise with other community agencies and service providers to meet the needs of the patients at discharge. They advocate for the patients where gaps in the service are identified. For instance, if we have workmen's compensation patients, we will negotiate reskilling from the Department of Labor. We provide education on the various conditions. Lastly, a safe discharge is as important to the social worker as a follow-up call or a session post-discharge. This is to ensure that everything is in order and the patient's goals for rehab were met. Thank you, ladies and gentlemen.
Thank you very much, Mrs. Dube, and that was wonderful insight. And before I click the next slide, I want to emphasize that the next slide was thanks to follow-up post-discharge. We wouldn't have seen the success or have known or realized the success without being able to follow up of beautiful Mrs.
Bana besi. Unkulunkulu uyaphila bafethu. Oye, amamiyoka. Hey! Ngawula champagne.
So I think I was as happy as that family were when I saw that video and they sent it to me. So what I'd like to share with you, even though it's been bits and pieces all over, is I have some take-home messages. The responsibility is on us and it's on you, that we need to consider the impact of what a medical illness might have on a person and their functionality. We do find people that are left at home and neglected when families don't know how to look after them. And sometimes it's just a little bit of input that can take them a long way. The evidence of insufficient provision of rehabilitation is massive. And I think we are all very aware of that in South Africa. And we all can work within low cost means. If some family comes to me and says, I can only afford 5 days, I will make 5 days work. And I think that's important. Rehabilitation is central to all of healthcare. And I think sometimes we only understand this when we experience it at home in our own societies and homes. It's not synonymous with therapy, as we've mentioned clearly. A comprehensive service with a team approach is critical because there's too many pieces that have to fit into the puzzle of something you didn't realize until some other therapist or some other person in the team mentions it to you and you go, oh, that's interesting. And it sometimes opens up and enlightens something we maybe didn't realize. Be very careful of restricted authorizations. So we need to help families to be aware. It's okay, don't panic. But sometimes I think the world is offered to them and then they don't know and come blindly. Equipment, I cannot emphasize enough, is critical to rehabilitation. And we have to get those authorization processes going as quickly as possible, ultimately to get the equipment and save costs. However, I'd like to caution that so often service providers jump on it in acute and get the wrong equipment, which ends up costing in the long run. And if not, sometimes funders, I have seen somebody with a wheelchair that's totally the wrong size and they would not refund it, and suppliers, which becomes challenging. Empowerment has a huge impact. So much can be done through family mediation. We don't have visiting hours. I want families there as much as they can be and to be engaged and work with us. And so communication essentially is critical. It is the thread that keeps everything together. And so in my next slide, I basically am saying, you hold the key to unlock the door. And we are actually begging people to please understand more the importance of rehabilitation in the process, because it has a massive impact on people's lives. And I want to see more Mrs. C's going through the door. And so I would like to hand back to Dr. Bella.
Thank you very much, Dr. Megan Knox, for this wonderful multidisciplinary presentation involving the whole wide spectrum of the team that you're working with, beginning from the hospital manager, Mr. Fabian Bennett, who is so passionate about making sure that the rehab unit functions as it is intended. And as you rightfully said, that rehab is not synonymous to physio. And I think most of us, and I think we make that mistake that we think that rehab is synonymous to physio, which leads me to the next question, maybe one of the other questions that have been asked by one of the people who are online. So the question is, which specialists do you normally work with? President Nyati says, I know orthopedic surgeon is one of them. Outside of the orthopedic surgeons, maybe just mention, is it all of them? Anyone can be part of yeah. Go ahead. Which specialists do you work with?
I would be happy to answer that. And I don't know if Dr. Mato would like to, but it actually is all. Because so often you can end up finalizing your acute process with any specialist, and sometimes even a GP who notices that the patient is not at the level they were before, which might have an impact. And that is actually the variable. If someone is not functioning the way they were independently before, there is this risk of, especially in aging, of decline happening, which has huge consequences.
Yeah. Dr. Martha, you want to chip in there?
Yes, please, if I may, Dr. Bila. Thank you. So
Yeah,
I think we work with all specialists. Anytime you have a patient who had some or other loss of function, whatever that may look like, whether it's a patient who's lost a thumb on their dominant hand, or a patient who's just had a hip replacement, or a patient who's just had a myringotomy and got loss of hearing with the ENT specialist. So a pediatrician who's got a child with CP. It really boils down to any time you've got a patient who's had some or other loss of function, or sometimes even a patient where you've treated them in hospital, but you are not sure that their home circumstance is such that they'll be able to continue their recovery. So that talks to discharge planning. So besides physicians, intensivists, orthopod, it's really any specialist who sees a patient and sees a deficit we are able to assist.
So any specialist who sees a patient and they reckon that this patient, in terms of the acute care, they've managed that, but there's need for a continued rehabilitation program, then they would refer to you, irrespective of the specialty or the discipline.
That would be correct. I know one orthopedic surgeon, for example, who said that if they do a hip replacement on a patient, if they send them to rehab, they consider that as a failure because it means they didn't do a good enough job with the operation. You know, a patient is beyond just good-looking X-rays and legs being equal. If that patient lives on the fourth floor of an apartment block that has no lift, that hip replacement is not going to be of any value to them. So it's up to us to then join in and say, listen, how do we assist? Speak to the family, speak to the kids. Can mom sell the flat and move into another place? That's the kind of work that we would do.
So it's a holistic approach to continued care, not just physical understanding of disease process. Absolutely.
A patient is more than just a hip.
Yeah. So patients who have had maybe a CVA, maybe a hemiplegic, and they developed a contracture, and it's for anyone, and how do you have such a patients? Now they may not have had rehab at the time when they were discharged, but now they've got a contracture. What is the role of rehab in such cases?
I'm quite happy there. It is always more complicated. I think the trick is trying to see what we think we can release. We need to determine in contractures. Sorry, I do have some hardy-dars outside.
Yeah, I've got my own hardy-dar.
Sorry, I hope you can't hear it. The one trick with contractures as well is to determine if it's soft tissue or are we dealing more in the joint, and especially in terms of if there's ossification. We sometimes as therapists detect that we're concerned it might be ossification, which then requires x-rays or checking, because if there is any sign of, be it myositis ossificans or heterotrophic ossification, we could make it worse by trying to force it. So we normally can feel soft end feels, hard end feels, is it hot, is it not? And then we actually do different approaches. We often start less invasive, soft casting, soft splinting, nighttime splintings. I'm sure people have seen splints that are made by occupational therapists, but with severe contractures, I normally try circumferential casting first. And we do serial casting as well to see if we can get it out. And then the trick is to try strengthen the muscle that it can overcome that. And if we can, that's a huge sign, because then you can start pushing. I have some fantastic, especially acquired brain injuries, where they're at high risk of this, because in the early phase, when they are still recovering, the tone is extremely high. And so they often, you can almost not prevent contracture. But with specialized, even bed positioning, when people are just left lying in beds, their tone increases further. So there's a lot of elements of therapy that know how to adapt the beds that help the people drop their tone, which then reduces the risk of contracture. And the same approach you use in recovery and rehabilitation. And then, of course, if things are extremely severe where we can't get it beyond that, we sometimes do resort to referral back to orthopedic surgeons, where we might do splats, Z-plasties, lengthenings, etc. Sometimes tendon transfers, etc., which we've had very good success with as well. So again, it's a team approach, problem solving, and starting conservatively. And of course, Botox as well. Sometimes Botox, we get really good results with that as well. I hope that answers your question.
Yeah, Michael others then says that the spine rehabilitation units work a lot with the neurosurgeons and the CVAs with the neurologists. Is that your experience? Is that how it works?
I think CVA particularly is a massively huge amount of our population. And so, yes, we do need to know what was the cause. And for example, like I said with the lady where we detected this lovely lady, the DVT, what is the management going to be? And so sometimes it is referring back and discussing. And especially like, as you say, with even if you're talking even tone and contractures, it's often good to check with neurologists, even if we're talking in terms of Parkinson's, multiple sclerosis. Sometimes we need to know the elements of where a neurologist has insight into why someone is presenting very clearly why they are. Not all therapists do always know that. And so the discussion ensues and you problem solve together and make a plan going forwards. And of course, spinal cord injury, especially if it's highly spastic or incomplete, a very complicated area as well, which puts them at high risk of pressure sores. But yes, you have it's teams.
Thank you very much. Yeah, I think we've covered a lot. I think this team approach, multidisciplinary, was quite helpful. Quite a number of questions that have been asked, but I think what I will do at the end of this talk, I'll ask Mr. Fabian Bennett to cover a lot of these other questions that are asked, in particular in relation to Solomon Sticks-Murray Hospital. There's someone who says, Ashraf, to me directly, or shouldn't have mentioned, very informative webinar, a reminder to us of the assistance available when we feel useless. I'm sure inadequate to deal with such cases, HCVA, autoimmune trophosis, muscular dystrophy, demyelination disorders. Yeah, I think these are some of the conditions that I refer to you, or sometimes there's a failure to refer to you by doctors who fail to recognize that there is a space for rehabilitation for such cases.
I would actually like to suggest and recommend that we are often, I'm sure Mr. Bennett is also right with happy with that, is when people do feel overwhelmed in certain facilities, we're actually very happy to come help and give guidance on some basic things to do in the acute phase. There's a lot of very basic simple strategies that can be used. And I personally feel our team would be quite happy to come out and train people and guide them and help them. And then we communicate further, where obviously then you can follow your patients and let's bring them across to rehab if we need to. And there's nothing more rewarding than seeing your patient getting successfully discharged. So I think that what is important is we all sometimes feel overwhelmed. I get certain cases where I feel like, okay, let's put our heads together. I can't problem solve this. What do we think we should do? Let's try it. Let's check again. Let's talk again, etc. It's teamwork. But we'd be happy to come out and guide and help people and train on certain things.
Yeah. I think what we'll do, we'll find another slot later in the year for continued discussions on this very important topic, judging from the amount of interest in this topic, that this is far removed from the public sector where things happen. But I think Mr. Bennett will cover that, because I think at Sticks we do not want only to work with the private sector, but also work with the public sector. So that is an opportunity, a great opportunity. But just before I give over to Fabian, just a question that has been asked about these webinars. I think there are new people who've just joined us for the first time at these webinars. We hold these webinars on a weekly basis, and we cover a wide variety of topics from different aspects. Like we've got a multidisciplinary team. Sometimes get orthopedic surgeons and neurologists. We've got neurosurgeons. We have physicians, nephrologists, you name it, and the nurses also who do present. When you get CPD points, so everyone, I see people have been sending information about their details of registration. Please note that once you register, give us the full information about yourself. Your name, surname, your profession, and the registration number where you registered in terms of the regulatory body, whether the Nursing Council or the HPCSA or allied health professions or pharmacy, or then we'll then send that information to the appropriate body that will then allocate points according to their processes and systems. But please note that we're doing that. But I'm going to hand over to Fabian just to do a rounding closing remarks and also do a thank you. Well, I want to thank you, Fabian, initially for availing this team to come and do this presentation and for the wonderful work that you're doing as the hospital manager at Solomon Sticks Memorial Hospital. And so that I'm not going to speak after you, and to thank Kamo and the team that have been assisting us, and Anza, who's going to be part of this team from going forwards. Fabian?
Thank you so much, Dr. Bila, and I really, it's always exciting as the leader of a facility to see the vision come to reality with amazing, compassionate, and highly skilled professionals who go beyond what's expected of them. Well, one of the questions that came up is, so what about the public sector? Well, I can't really interfere in the public sector, but what we have done as a role player in society, we do accept all RAF patients. We do accept all COID patients. We accept all medical aids, but we've also developed highly affordable, creative cash packages for families. So we have field case managers. You give us a call, the field case manager will come out, assist you, assess the patient, meet with the family, and we'll find creative ways. We also have a walk-in facility. So on any day of the week, a patient can walk into our facility for an assessment where we can work with them to develop a plan and find not only a clinical and therapeutic plan, but also find financial alternatives for them and creative ways. We are committed to accessible, affordable, quality care, and we really, really practically show that. So please speak to us. We have arrangements with the various departments of health, and we have formal relationships with the Road Accident Fund and COID and other employer funder groups. So we are very excited to do that. We are committed, and we've shown through this case, but we've got many more cases, that our commitment is improved functionality in the shortest possible time at the lowest possible cost to the patient's highest potential. And we are really appealing to the community. Talk to us about those patients. Let's find creative solutions. The ones in the public sector, give us a call. Our teams can come out and assess. They can work with you. You know, I always say to the team, rehabilitation is also just helping even a patient die with a smile on her face when she couldn't smile, but also the ability to sit in the bed and sing with the family or clap her hands in the last moments of life. So talk to us. Rehabilitation is really a broad area, but I'm very proud, Dr. Bila, to be leading this team, an amazing team. I think lastly, what I want to share is the benefits we also have is that the rehab facility is situated within a holistic rehabilitation environment. We have mental health rehabilitation, we have substance abuse rehabilitation in the same facility. So even patients long post-trauma who have opioid dependence, our multidisciplinary team on the physical side will also partner with the team on the substance abuse side to help opioid withdrawal and assist with pain management and remodeling the patient's management of that pain. So also patients dealing with depression, severe post-depression. We have a sexual health expert and a psychologist on our team who assists the male patients and female patients restore their dignity from that perspective. So we have really reimagined rehabilitation. We continue to reimagine it. And if you would like, please come and visit our facility at any time. Just walk in and ask the team to take you around. Thank you so much. And thank you for joining us this evening. Thank you to the clinic's clinical team, and more importantly to our partners. Thank you.
The question is, where is Solomon Sticks Memorial situated?
We are situated in Elf Street Extension, downtown Johannesburg CBD. if you Google us, you will easily find the location, and we are quite centrally situated. We will send the location in the feedback when you supply your feedback, and we're also going to send you a list of our team members so that you can meet the team virtually. Thank you.
Thanks a lot, Fabian, and thanks, colleagues. Thanks, Dr. Megan Knox and the team. Yeah, and for joining us this week. And we, Martin, please mute yourself. We hope that you will join us again next week as we continue with our webinars on a weekly basis. And those who are joining us for the first time, please do come back and have a good night. Thanks. Bye-bye.